I don't know, 15 other colleagues of hers just published a very good paper that just got accepted. You'll probably see it on that feed that you get too, Ken.
Yeah, I think that that one of her slides that show that how they're using that chamber to do the testing.
Yep.
I think that would really hit home with some folks, because they can actually know that how the testing's being done, right?
Yep.
You know, it's in a controlled environment. So how about when it's outside a controlled environment?
Yep.
All right, I think we have almost everyone. We're just missing one person, and I'm not sure that he was even on yesterday. So I think we are good to get started.
Excellent. Thank you very much, Alice. I appreciate that. I'll just start it out, and then I'll turn it over to Bernie and let him do a recap of a quick recap of yesterday. But as you know, we're getting into the COVID-19 discussion. That's the big topic today. That's what's on everybody's mind. But I would like to say at this point in time is we cannot only think about COVID-19 and our workforce. There's people getting killed by falls still, caught in betweens, electrocution, the fatal four that we all know about. So we have to make sure that even though we need to make people aware and cautious of the COVID-19, we still have to keep them safe of the other issues facing us on a job site. So I think when you're teaching your class and we're going over COVID-19 and we're going over ICRA and we're going over, that the topics that are going on today, we need to make sure that our members understand that that's not the only thing facing them on a job site. And that we, just want to reiterate what we brought up yesterday, that the PowerPoints will be updated after next Thursday and Friday. Then the following week, they'll be put onto the LMS. If you need material before that, we can give that to you. Just remember that it's going to be updated. So I just want you to have that in mind if you need those. But we're going to adjust it and update it per your feedback. And also remember, they're living documents, so keep an eye on the changes that's going to happen periodically. And I'll turn it over to Bernie to do a recap.
All right, thanks, Ken. So again, the first part of yesterday and the first part of this awareness program, which is realistically, it's two modules. It's infectious disease and ICRA. But as I said, the COVID-19 piece, since we're in this pandemic, is very important to cover more specifically. And also it's part of the auxiliary funding that the CPWR got. But, a year from now, year and a half, something like that, that COVID-19 piece will be shrunk down and put underneath the infectious disease module. So then you'll have two modules basically for this awareness class, and they can both be taught independently. Although to understand ICRA, you really got to make sure that your audience has a firm understanding of infectious diseases. Does anybody have any questions or anything that was lingering from what we covered yesterday? Okay, good. I just want to follow up on something that Ken said, about the other hazards that, you're going to face every day on a construction site. One of my concerns is that with the lack of N95s and PPE and this issue on face coverings, which are important to reduce the spread of this, I'm concerned that the normal construction and non-construction airborne hazards that we face are going to be overlooked and dumbed down through this. Because I think that one of the things that the COVID-19 response has showed us all is that there really is a basic lack of health and safety on many, many job sites in different industries, whether you're at a manufacturing plant or you're on a construction site. I mean, the fact that I've seen employers ask basic questions about medical clearance for respirators leads me to believe that they don't even have a respiratory protection program, which is required by law. That's a bare minimum. That's like the first mile of a marathon right there. So that concerns me. And I saw a colleague of mine discuss this in a feed this morning, And he said, what's going to be next? Are we going to replace metal machine guards with cardboard? Right. So this is something that we don't want to lose focus on, is that the face coverings, the cloth masks, the allowance of medical face masks is there because we don't have the N95s like we should have had. And this is what we're doing to sort of limp to the next phase of fighting this pandemic. But these things do not replace an N95, or even better, a half face or a full face elastomeric respirator with appropriate cartridges if you're welding. I mean, let's face it, as painters and glazers and the other allied trades that you've got under your umbrella, you actually deal with a bulk of chemicals in the construction field, right? Those are the types of respirators that you really need to be relying on. So I just want folks to not lose focus on that, not just during the pandemic, but after we go forward. And that's something to pass on to your members and the folks that are in your classes, how important real respiratory protection is.
Hey, Bernie, can I add a little bit to that too? Because I think that's very, very important. And I might have been reading some of the same articles as you're reading and talking to your colleagues, but we ran out of N95 masks, which we should have had, right? That's what people should be wearing with this stuff. And so they said, since we're out of everything, let's just, let's go to face coverings, right? But it's to say that somebody's 100 feet in the air, I'm out of tie-off gear. Do I say put a waist belt on now? Or do I say just use a rope, or, we don't have a rope, so we'll just hold a person's belt buckle. And that's basically how we went down to the face covering, is we were out, so they just substituted something less safe. It's got some feasibility to it, but it's definitely less safe, and it's the protection factor and all that stuff. It's not meant for what it's doing, or what people assume that it's doing. And so, and then with all this face coverings and mask and respirators, I mean, everybody's calling everything a respirator now, or everybody's calling everything a mask now, and that's not the case. So just remember that your members have to understand, just because a contractor doesn't have a piece of safety equipment that is approved, doesn't mean that they could substitute something less safe for them to use without having approval. So I just wanted to add that, Bernie.
That's right, Ken. That's right. No, that's a very good point. And nor can they say, oh, don't worry about it. Get to work today, and I'll make sure I get this in tomorrow or by the end of the week. Right? Let's review labor history for a moment. The first reason that unions were formed were not for better pay or vacation days. Those things are good. But it was literally because workers were dying on the job in such great numbers, they weren't coming home to spend their paychecks. So, health and safety is a serious union, cornerstone. So that's right. So let's use that and get into our next set of slides here and go through. And I'm just going to point out some stuff. And again, this is really important for you as trainers when you're speaking to your members about this and your participants, because of the mixed messaging that we got. Initially, in fact, you might not even remember this, but when this first started, the CDC had social distancing guidance of 3 feet, not 6 feet. And then they started to mix it up. They said general public has to stay, 1 meter or 3 feet apart. Police officers and some other responders have to be 6 feet apart. Well, wait a minute, why are those populations different? It's because the truth is scary, unfortunately, but you can't stick your head in the sand. So what do I mean by that? So we look at how these infectious diseases, as we discussed before, especially COVID-19, now that we're focusing on this module, is spread. It can spread through droplet, aerosol, contact, and other possibilities. And in fact, I need to completely rework this slide. And Alice and Ken, Nicole, and Donna, I need to rework a lot of this now because a ton of brand new information just came out this week. I have not even had a chance to read through it all. But it's very pertinent to how we're going to process this COVID-19 issue going forward. So droplet respiratory secretion, again, it's large stuff. You might cough it out, and they're so large they just fall right down within a few feet. Aerosol transmission, though, they're much smaller things, and these are the droplets that are around 5 microns or less, very tiny. You can't see them, and these things are going to just stay suspended on the air and travel a great distance. Contact, just to review, is you get maybe some saliva on a tool or on a surface. You touch the surface, you rub your nose, your eyes, and you transfer it that way. And then there's other routes that are possible for transmission of COVID-19, including fecal matter, but that was one of the least transmissible routes that we've been looking at, because again, it's airborne transmissible. All right, next slide. COVID-19 airborne transmission is a key factor. So we know for a fact it's airborne, without a doubt. It's not just considered droplet, which means, at 6 feet, you're fairly safe. No, it's airborne. It's gonna float around. It's gonna cover great distances up to 25 to 30 feet. If you're indoors, it's even worse. Your risk goes up, and you're gonna be relying on your ventilation system if you've got one. I don't know how many people here have kids that are in elementary school, middle school, or high school, but how many people's children's schools don't actually have a centralized HVAC system that services the classrooms? Now, mine have some systems that service, the administrative offices, but not the classrooms. Their ventilation system right now, or at least usually during the summer, is they open the window, right, and let the kids sweat and stuff and expect them to sit still. Boy, I remember those days.
Hey, Bernie.
So imagine that as your ventilation system, right? How many people here have been to a restaurant, maybe a bar, maybe a nightclub, something like that, and the air just feels stifling, it stinks, and you don't feel comfortable? That's a sheer sign that something's not right with the ventilation system. So being that this is airborne transmissible, very important that we've got methods to combat this that is more effective than just staying 6 feet away from somebody.
Hey,
We
Bernie,
know,
and there's research out there today that shows that it's been transmitted that way.
Yep.
There's been studies out there that shows that people in restaurants
Yep.
have contracted the virus by the ventilation system.
Yes, Ken, and I'm going to credit Ken for finding this one first. Months ago now, I think Ken found a news article about a study that was done in China where a Wuhan family, one of the members was sick with COVID, visited another province in China, went to a restaurant, and based on, it was like a wall ventilation unit, air conditioner, and it was just basically circulating the air at one end only of the restaurant, not putting in fresh air, just recirculating the air and decondensing the water out of it so it would get drier and cooler, etc. And so the tables that were in line with that airflow, people got sick there, but the other people in the restaurant didn't, and they were able to model the air circulation in that restaurant, and they were able to show the only way that the other people in the restaurant got sick was due to airborne transmission and air circulation through the room. So this has a lot of profound impact on how we're going to be addressing this in the future. So transmission, the transmission modeling about this has been telling. They've also found RNA, so basically parts of the virus that's no longer infective. They found it on air pollution, particulate matter. I think I gave a reference to this yesterday. This could be, pretty important if they're finding infective or quote unquote live virus on air pollution, because that's going to be really difficult to deal with. And we got to stay tuned for this. This, again, it's evolving so quickly. Next slide, please. So it's really important to get across to your members, look, just staying the 6 feet away isn't going to do it. And I get it. The mixed messaging out of the CDC has not been good because the narrative has been controlled contrary to science. You might remember if you were on, I think one of my first sessions with the IUPAT, I gave a brief talk about some of this stuff. And one of the issues I talked about was The CDC said that N95 respirators don't protect you from contracting the virus, and don't use them, by the way, because we need to keep them for our frontline medical care workers, right? I don't know if any of you, if you remember that when I gave that talk. Well, which is it? Either it protects you and me and a doctor or nurse, or it doesn't. So why do you need to save them? So the messaging has been very convoluted. So, you know, we have, I think, the onus here. We have a duty as instructors to be able to present the correct scientific information, where 99.9999% of experts are in agreement of what this stuff is, how it behaves, how we're going to protect ourselves, our family, and the public against it.
We got a good question, Bernie.
Yeah.
From Christian. It's a question that I have heard the CDC has redacted some of the statements regarding how long they can survive on a surface.
Yep. So I saw that, and Kenneth saw that, and I talked to a number of my colleagues about it. We believe at this point it might be a political issue because it's very expensive to keep businesses open with this level of cleaning that's required. My advice and what I'm going to do is that until I find studies that contradict all the other studies that show how long this stuff can stay activated on surfaces, we need to keep, you know, preaching and practicing what we already have been talking about, how long this stuff stays on surfaces. And with that, let's go back to the point I just visited. So the CDC has softened some of its language. Now, when they changed it on the website, they didn't make an announcement. In fact, I went there the day that they changed it, thanks to Ken referencing a news article. And they didn't have a news announcement. Like, they'll always have a press brief, you know, just announced on the CDC COVID-19 page. They didn't do that for this. The other thing is they have not removed all of their constant guidance about always cleaning, always washing your hands, always cleaning and disinfecting surfaces. So which is it? Is it not going to be lasting on surfaces, or do you want us to keep cleaning? This is, as a scientist, it's scary stuff when I see, you know, contradictory information like that out of what used to be a very reputable institution of the CDC. And there's still a lot of awesome scientists and experts there doing good work. But unfortunately, I believe that they've been silenced to some extent. In fact, one of the colleagues on the outbreak group that Ken and I are on, somebody said about a month ago, "Can I please have the old CDC back?" Which would be great. And it's unfortunate because we need them. We need their unfettered opinion on the science. With that said, I'm going to revert to what we know. You know, different materials are going to allow this stuff to last for different time periods. Copper, about 8 hours. And again, copper is somewhat of a disinfectant, so to speak, against different pathogens. So I can understand the low level time limit there. Cardboard up to 24 hours. Stainless steel and some other hard surfaces like hard plastics can up to 3 days. And on the bottoms of shoes, they found it for up to 5 days. All right, next click, please.
Hey, Bernie, there's a few participants with their hands raised.
Okay. I can't see that. Okay, yes,
Yeah,
go ahead.
so,
Just shoot away.
Sean, I want to go first. Sean, you have a question?
Sure. So what about is a ceiling fan a bad idea in a big building? Is it just spreading it around, or is it better to have air moving in the building?
Yes. So again, this is getting into the stuff that just came out this week, and I glanced over it. So I reserve the right to amend my opinion. But if I reference that study from the Chinese restaurant, they had that wall unit air conditioner that only recirculated the air in the restaurant in one direction, and basically it would bounce off the other wall, adjacent wall, and would kind of come back and keep getting recirculated. So it was making like a loop, a continuous loop of air. That was not filtered in any way. It was only recirculated and condensed to remove the water vapor. They believe that's what caused the infection spread to the other members in the line of that circular air pattern. So if all you're going to do is recirculate the same stagnant or stale air in your building, that's probably not a good idea. You need to introduce fresh air into the building if you're going to use something like a ceiling fan. Without the introduction of fresh air, all you're doing is you're going to stir up the virus. So
Okay.
that's a really good question. And
Thank
I got a couple questions like that we're going to be doing this Q&A session next week. And I'm going to try to address that as completely as I can, hopefully with the ammunition of the new research behind me. So good question, Sean. Who else had a question?
Nuno? Portela?
Yeah, Bernie. So going back to the N95 masks, you have the N95 without the one-way valve and the ones with the one-way valve, which is really allowing you to breathe out. The droplets are still coming out, probably not being projected as much as a sneeze. But what's your take on those? And would you recommend the N95 with or without that vent?
So right now in the literature, I don't think I would be able to find anything that would give you a good definitive answer on that. My first professional opinion, though, is use one of those that a worker is more comfortable wearing correctly so that they'll keep it on, right? If they have a better time breathing with the exhalation valve in it, have them use that if you can find them. If it doesn't matter, wear whatever N95 you can get, because they gotta want to wear it, and they've got to wear it correctly. And there was a study that came out about 5 or 6 years ago where a number of industrial hygienists and other occupational professionals looked at the effectiveness of the efficiency ratings of different respirators. And actually what they found was that an N95 wasn't 95% effective against aerosols of an average diameter of 0.3 microns. It was more like 80% because of people not wearing them correctly. So one of their guidance is, well, look, if you need something that needs N95 efficiency, throw on an N100, because that extra, 5% efficiency roughly is going to help protect a little better when people aren't using it correctly. So whatever you can do to get people to wear it correctly, go with that one.
Yeah, I was just wondering about the actual contamination, because the
Yeah.
N95, if you're wearing it with or without that vent, you are protecting yourself.
Yeah.
However, are you really protecting everyone else from spreading through the droplets that come out of that one-way valve? Because you are not intaking it as much, but you are still breathing out, the droplets still coming out through those vents.
That's right. Yeah, because it is a small portal, but yeah, as you're inhaling, that's supposed to shut down so that only the filtering face piece is allowing air through. And of course, if you're going to breathe out, that valve opens up. It is a small portal. Look, I think realistically, yes, some of what you're breathing out is going to get out through that. How much, I don't know. Is that a better protection for other people in the surrounding area than just a cloth face piece? Absolutely.
Thank you.
Yep, absolutely. No, you bring up a good point. And again, some of this, that's why the definition of industrial hygiene, it's not just the science of evaluating work environment hazards and implementing controls, but it's also the art of that, because life is just muddy. It's muddy.
You got two more questions.
Yep.
One from Omar Robinson.
All right, let's hear it. Who's first?
Omar?
Hey, Bernie.
Yeah.
You made a lot of reference to mini split units. Central air conditioned units.
Yep.
I think maybe a lot more dangerous than those mini splits, because this thing is running through an entire building. Should we be looking at scrubbing units within those central air conditioned units?
Oh boy, you guys are really weaving together a perfect quilt here. So this is exactly all the research that's been coming out this week. I think I've got 5 or 6 papers specifically speaking towards this. ASHRA, the HVAC professional group, the American Industrial Hygiene, a month and a half ago, we're talking about some of this stuff. So what we do know, and what I can tell you right now definitively, is, again, recirculating the air without filtering it in the HVAC system is not too good. You don't want to bring it up from one spot where somebody might be potentially infected and then dump it in another part of the building. However, we don't know how long the stuff is going to survive inside the HVAC unit itself. But if you're recirculating the air and dumping it into other parts of your building through an HVAC system within a day, that could increase risk to other occupants. So that's something that we have to look at. Again, the current guidance is, MERV 13 filters or higher right now, as high as your HVAC system can handle. Open up that the damper so you get as much outdoor air as you can put into your system, and do not recirculate air without filtering it. So that's what I can say right now, and I'm going to address that question as well Tuesday when we do the Q&A with a little bit more confidence with the new research behind me.
So we're going to get a couple more, and then I'm going to let Bernie move on. If you guys, if there's because I want to answer all your questions. I want to be able to get to everybody's question. I'm going to move to Harry here in a second. But it's make sure that if it's something that it's really, really dire need, and that so we can get through the material, make sure it goes into the chat section also, so we can have a documentation on that, and then we can really, really get to your questions and be able to answer that. So, Harry.
Mine's actually more of a statement. I just was reflecting on how you guys were talking about when you went from M95 to cloth face. They said, we don't have enough M95, so let's go to cloth. It was kind of strange that no one said, hey, let's go to half mask or let's go to full face, and that was it. It was just a statement.
Harry, good statement and good catch. The reason why they didn't do that is because it's too damn expensive. Workers aren't worth it. Sorry for my pessimism. I've worked with the SEIU with their nurses about 10 years back, specifically focusing on respiratory protection fact sheets. And at the time, Mark Catlin, who's since retired because I think the SEIU disbanded their health and safety department, he was wonderful IH. And I said, Mark, look, why are you having so much trouble, upgrading to elastomeric half faces? He's like, too expensive, Bernie. He's like, I'm having trouble even trying to get hospital administrators to agree to N95s. I hate to say it. It's literally, dollars and cents. And not for nothing, since we're talking about, unionism here and organizing, the more you give in to workers like that, you're letting them have some power, right? You're letting them have some ownership over their work. It's a terrible cycle. So very good point, Harry. But not for nothing, I do think we might have mentioned this at a couple of our info sessions with members that, if you have elastomeric respirators and you've got, a HEPA cartridge, and of course, an appropriate combo cartridge for the work that you're doing if you're working with, organic volatiles or things like that. If you've got an elastomeric with a HEPA on it, use that. It's better than an N95. Use that. All right. Ensure. Okay, so I put this up here. This is really important just because we've been looking at using different application methods of disinfectants. So you want to get one that's on the EPA N list, and you got to make sure that you're using it in accordance with the label, and also that EPA is approved, the method. And I'm speaking specifically to foggers, high volume sprayers, and electrostatic sprayers. So next, because some of the, I guess, different districts or some locals have been looking into using some of these different application methods, not just for the training centers, but potentially as a vehicle for work. And you just want to make sure that you're first off using something that's effective and safe for not just the community, but the workers, and also that it's legal. We want to make sure that it's approved to use and that the application method is approved. All right, next slide. Incubation period, so we know it's 2 to 14 days. And we also know that folks who are infected can be contagious without showing symptoms. Next. So this is an updated slide. I showed this, I think, during our DOT seminar that we did a few weeks back. The symptoms list has expanded. Chills, repeated shaking with chills, muscle pains, headache, sore throat, loss of taste, smell. Also the multi-inflammatory syndrome. So we saw this first with children where they're getting these large rashes all over their body. and feeling weak, not being able to breathe, almost like they're having an asthma attack. And we've seen this now in a couple of adults as well. Percent of population that could be asymptomatic, up to 50%. I've seen some issues or cases where it's been higher, such as the USS Theodore Roosevelt aircraft carrier. Up to 60% of the sailors there who had COVID-19 were asymptomatic in the beginning. And then there's the issue of the Boston shelter. I want to say Pine Street shelter. I can't remember the name of the shelter now, but they were using temperature checks to qualify folks to be able to stay in the shelter overnight. And they looked at 397 occupants, 146 tested positive, and none of them had symptoms. And the only screening that they were using was a temperature check. So we have to be cognizant, if you're just relying on looking at symptoms, especially one symptom like a temperature, you are going to be letting some potential positive people through. You'll also be catching some potential positives as well. But it's not foolproof. If you're infectious, if you're asymptomatic, you can also be infectious. And there's no evidence right now that infection builds immunity. And I just checked on the WHO webpage considering this yesterday. I hope it does. I hope if we do get it, that we have enough antibodies that we will be protected from it to some extent next go around. Next, please. There's my hope. Severe symptoms for COVID-19. So most people do have mild symptoms, but that's not true for everybody. Obviously, if that was true, we wouldn't have 105,000 fatalities just in our country alone right now. And again, one of the issues, big difference between this and seasonal flu, you might have your symptoms and be down and out for around 10 days or so. We've got people with this, the average time is 15 to 20 days. We've seen some hospitalizations last, past 20 days. Next slide. Poses greater risk for certain groups, underlying health conditions like I might have. I've got asthma, so it's not recommended I go out and try to get infected until we have a vaccine. Heart disease, different lung diseases, diabetes, immunosuppression of any kind. Elderly have higher susceptibility to severe outcome. Fatality rates among African Americans and Hispanic Americans are disproportionately high to other ethnicities. There's a number of reasons behind this, one of which I'll point out. There's just been a health disparity among those populations since I've been alive. That's one of the issues. Children and younger adults have had less severe illnesses and fatality, but again, not immune. I'm sure you've seen, some cases in the news of infants dying of COVID-19. Because COVID-19 is new, there's a lot of stuff that we just don't know, including, how it might affect women who are pregnant. With that said, regardless of underlying risk that might increase your severity, it doesn't mean that you're just not going to get it. So if you're completely healthy, you're a young guy or gal, you love doing Spartan races, you got a good time in that, you're exceptionally fit, it doesn't mean you're not going to get it. It means that your severity of symptoms is probably going to be less than those who might have an underlying condition, okay? Okay, next. I'm seeing the chat box click up. Is there anything that we should address now?
Let me see. Yes, we got does UV light kill COVID-19?
Yes. Yes, it does. With that said, we have to use an appropriate application of UV light, right? So there are some systems that we can put indoors. There are upper area UV light emitters, which are installed like within the top foot of a ceiling, and that broadcast a blanketed directional wave of UV light, UVC light, up in the ceiling. So it's not around where your eyes are or skin. The only risk would be if you were, a teacher or a janitor, something like that got on a ladder and had to do something up in the ceiling. You've got to make sure that that system is shut down. And based on the gentle currents from our body heat, air rises in a building. And so as the COVID-laden air gets up towards it, it zaps it. You can also put it inside ducts, and you can also treat filters with it, although it degrades the filters a little bit. But yes, you can use UV light as a control when properly administered. Good question.
And I think this question's also really good, Bernie. So how do we build antibodies if we are not exposed while in quarantine? Don't our immune system weaken?
So no, I mean, so as long as you're being healthy, right? You're eating well, you're getting enough sleep, you're managing your stress, because we know that stress can weaken your immune system. You know, your immune system is going to be running okay, but it doesn't mean that it's going to be able to fend off something that's brand new, like the COVID-19 virus, right? So the way that you would build up antibodies to that, a safe way would be with a vaccine, which we don't have right now. The unsafe way is if you got infected by somebody, in which case you would more than likely build up antibodies, but we don't know to what effect those are going to have for a secondary infection to you. So that's a good question. So
Thank you.
rolling the dice is going out in public and trying to get infected. We don't want to do that. Not to mention that aids in the spread of this. Good question. All right, next. Treatment and vaccines. Again, no vaccine right now, no treatment that is accepted by medical professional organizations to treat COVID-19 if you're sick. It's basically just making people comfortable, assisting with fluid intake like an IV, and also assisting with respiration if need be, like intubation and putting them on a ventilator. But right now there's nothing. And just to put the hydrochloroquine to bed, not only does it not work, we now have plenty of studies that show it increases potential heart issues and fatality. So don't want to go down the COVID, the hydrochloroquine road. Next, protective measures. It's going to be similar to the stuff that we covered already in infectious diseases, but precautionary principle. This has been around for a while. I think it was originally born out of the environmental science field. Basically, without understanding something very well, without understanding the science behind something and what you can expect for outcomes, err on the side of caution is basically what the precautionary principle is. So in other words, operate in an abundance of caution. I've heard the phrase recently. Next slide, please. So what can we do? We've been going through this stuff quite a bit. The more legitimate information that's valid that you can give your participants when you're teaching this stuff, the better. And again, this is changing a lot. So I'm going to try to update this for our next go around next week on Thursday and Friday. And then after that, I'm going to give it another revision. So I'm going to make sure that we've got eyes on this and it's constantly updated as necessary. Washing hands, cleaning, sanitizing, avoid touching your face. I've done it already probably 20 times just when we started talking since 1 o'clock today. It's human nature. It's very, very difficult to prevent. Stay at home if you're sick. Again, this connects to, do you've got a good health sick policy at work? Next. Cough or sneeze into an elbow if you can, or a tissue. Clean and disinfect frequently touched objects and surfaces. Be prepared. So this is already getting, we're already in the middle of this, but this slide was prepared as we were getting into the pandemic. But with that said, there's going to likely be a second wave of this, and there's going to be another epidemic or pandemic coming down the road in our lifetime. Hopefully it doesn't happen in a few years. Hopefully it's longer. But again, if you can create a good training center plan and work with other, construction unions to make sure that employers have a good construction site infectious disease program or a pandemic plan, there's a number of phrases we can use. That's going to allow you to seamlessly transition from being able to move from a training center to doing some stuff from home again, seeing who might be critical to stay on board and how you can protect those folks, maintaining your building when this happens, implementing the right stuff on a construction site, etc. So we don't want to say, okay, the pandemic's over, let's go back to normal. No. If you look in cases that have been discussed with different locations around the country, A lot of places have actually had pandemic plans. In fact, we had a national pandemic plan that got deep sixed a couple years ago. A lot of large organizations in cities, like, for example, the city of New York, they had a pandemic plan which revolved around a strong centralized federal government assistance. These plans have been out there. We have to make sure that they're continuously dusted off, revitalized, updated, and practiced and used. I don't know if anybody has ever participated in some of the national disaster exercises that we used to have that were going on through the Bush and Obama era. But we had things like the national top-off events where they would have a simultaneous tertiary event. So, the East Coast, Central, and West Coast America would each have a major disaster event, training session, and all stakeholders would be involved. And it would be a whole day's event, and then they would have a debrief. These things are good. We should keep doing these things. And this includes pandemic and epidemic response planning. Next, please.
We got a question,
Yeah.
Bernie. Can a vaccine work on a RNA virus?
I don't know. That's a question I don't have expertise on. I can look it up and get an answer for you if we can remember that question for me.
Yep, done
Yep.
deal.
Next question. 5 steps to proper hand washing. So again, basically you got to make sure that you're using soap and water. It's the best way to do it. It's that mechanical action. That's one of the reasons why the most common disinfecting directions on a lot of these endless products are, a rag or a sponge and mechanically washing a surface with it, because that mechanical action is going to help break down stuff. What else here? Oh, sorry, folks. My phone has just done something not good. All right. 20 seconds of hand washing. You've probably seen a lot of different songs out there. My favorite is The Rock's You're Welcome song, which is good. So whatever you do, you don't just want to put soap on and quickly just lather up and wash off and you're done. So as far as training centers are concerned, you want to make sure that you've got a policy for not just staff, but participants that come to the training center to make sure they're washing their hands regularly. And if you're at a construction site, we've got to make sure that employers have access to workers' wash stations that are full with water and soap, whether it be a portable system or they've got actual, hard piped laboratories. Next. If you're sick, stay home. Obviously, this revolves a lot around a good employer sick policy to make sure that folks don't have to feel like they've got to go to work. Also, we don't want to have somebody think that, maybe I just got seasonal allergies here. I feel really under the weather. I'm just going to go anyway because I don't want to burn the sick days I've got. If we've got a good, strong sick policy, somebody can stay home like that. And if they're potentially sick with COVID, not infect the rest of the population at work. Next slide, please. What can workers do? So a lot of this is common stuff. We cover a lot of this too in the fact sheets that we put out through the IUPAT as well. Avoid large gatherings of 10 or more, stay at least 6 feet away. Okay, we've got to update the slide, obviously. The issue is there is a big difference between risk if you are working outdoors with good, wind blowing around, and if you're working inside. And I know that a lot of IUPAT members have the potential to work in both areas. If your work is replacing glass, in a hotel that's already built, maybe you're renovating, refurbishing rooms at a hotel, that's an indoor area, and I don't know how good their ventilation systems are, but if you're working in groups, your risk is up. If you are painting on an outdoor liquid propane gas tank, much lower risk, right? If you're working around other people. So we have to consider what kind of environment we're in. Next slide, please. Keep going. Again, basic stuff for the whole population. Cover your mouth when you cough or sneeze or into a tissue. Wash the hands often as possible. If you don't have access to that, hand sanitizer. Next. Bring food and water from home. Have your own water bottle. You know, the days of, you know, buffets and things like that might be at a standstill for a little bit. Job site picnics, etc. You know, drive to work site. So this is a big thing, and I've mentioned this a lot. It's not just, you know, I've got a hazard here of climbing up a ladder, I might fall. This is something where your hazard starts from the day you leave your, you know, the moment you leave your home. If you're used to commuting on a commuter rail or a bus or doing ride sharing, that's going to expose potentially other people or yourself if there is a positive COVID person there. So you want to be able to get to work on your own, which brings up other issues too. If you're working in a city, you know, in Boston, parking is terrible. So if I'm used to taking a bus in and then walking, or I'm taking a commuter rail, what do? Is there going to be a parking lot set up for me as a construction worker that I can get to easily? Next.
Bernie, I'm going to add, let me add a little bit to that too. You know, what workers can do. Also, we can't forget the fact that what we're in at work, we can't bring home with us. I mean, we alliterate that so much to our membership that, you know, if you're working in a dusty area or you're painting with chemicals, and we have to keep in mind that, you know, we got family at our house. And I just want to add a fact, you know, my career started out in asbestos and hazardous chemicals. I have a washer and dryer in my garage because somebody told me that I should wash all my work clothes within that washer and dryer. So it comes to the fact that it might be a good idea after work to change your stuff before you get in your vehicle that your family's going to be in, or change your clothes before, you know, you put it in the same laundry basket as others. So we just have to keep in mind that it's the unforeseen hazards that we're bringing home to our families.
Yep. And all of that goes into risk reduction. So, you know, I've said this many times. There's a bunch of controls. The more the controls that you can do and the higher powered ones that you can do, the more you're going to reduce your risk. As a person, you've got to get your risk down to something that's acceptable for you and your family. As an employer, you've got to get the worksite risk of COVID-19 down to something that's acceptable for workers to feel comfortable coming to work or staying home from work if they might be sick, right? Because that's what's going to keep the job open. Good point, Ken. All right, next slide. There you go. There's your washing machine, Ken.
There it is.
That's a nice one. All right, next slide. Recommendations for employers. I'm just going to mention, have a COVID-19 worksite plan. We've developed one as a model that you can access and look at. I'm not sure exactly where you're storing that, Ken and Alice, but that is accessible for you. And basically that's going to cover all the interventions or controls that an employer will have, including having a COVID-19 officer that's responsible for all of this, including having a responsible, you know, general contractor person who can authorize resource use, which is important. And that's going to have everything in there, including a sick policy, you know, controls like PPE, ventilation, hand washing stations, etc. Next, please.
I'm going to add to that too. A COVID-19 officer, safety, whatever you want to call that person, we really need somebody. I mean, this is my opinion, dedicated within a training center, right, to make sure that policies and procedures are being followed. And then, you know, also hopefully that the job site has the same, because there's a lot of things that person needs to look out for, and what they're doing is just making sure that things are put in place so we don't, as workers, have to worry about that. Instructors at a training center need to do the same, is have all this stuff in place and verifying it by maybe that person that's has that duty, so our members don't have to worry about it while they're in the training center.
Yeah, good point, Ken. And I'll be blunt. It's labor intensive to be a COVID-19 officer. How many people here have done a job safety analysis or job hazard analysis? That's observational work, right? it takes time. You can't just glance at a paper. You got to go and watch somebody do some work. So things about how are the groups of workers working together? Are they spread out enough? Are they indoors? Do I have PPE? That's going to take time. So we'll just go through this slide as well. We can skip over this one.
We have a comment
Okay.
somebody would like to make. Christian?
Yeah, one thing to keep in mind is protecting the construction site is going to have different rules than protecting an office space or training facility, because one is going to fall under construction OSHA or state OSHA versus general industry terms. And from our personally in Washington, the construction side of it is there's a lot more required as far as what needs to be done in the policy. And in particular, like Ken mentioned, there is a supervisory social distancing cop on construction sites, and then a manager for office spaces. And
Christian, I think, oh, go ahead.
yeah, go ahead. And
No.
I've had to write both of them. So, and there are some templates, and it sounds like FTI has some also, but AGC has some good ones also.
You brought up a good comment, is that while we're teaching this course to our members and all that stuff, it's impertinent that we stay up on state and federal regulations of how we're supposed to deal with this. So we might have a federal regulation, a federal OSHA regulation, or just a federal in itself, or we might have a state OSHA RAN program that we have to follow. That could be more, because as we know, OSHA is a minimal standard. And there could be other state laws of state rules that govern what we need to do in that particular state compared to others. So I think it's good to stay updated on that also. Great question.
Yep. Yeah, all good input. So, I mean, the folks who reside in California, I mean, luckily you've got an airborne transmission, standard, the first of its kind in the country. So if you haven't already, I would check that out. I would look up the Cal OSHA's airborne infectious disease standard. All right, next question. I should say next slide. How are we doing on time? All right. Just more, the general recommendations for employers. Next slide. Keep going. All this stuff hasn't been changed from the slides that you might have seen when you took the course. Next slide. Some of these things, though, okay, so we got our next activity. A lot of those slides, I'm going to have to go back. I will update. I'm going to try to do as much as I can for the class next week. I just don't know how much I'll be able to get up to, but the following week, I'll make sure that it's updated from both classes and that the most pertinent, up-to-date information for COVID is up there. With that said, oh, go ahead, Ken.
Bernie, I just wanted to add that, as you guys are teaching this course also, if you see something that that you see that needs to be updated, or something that we might have missed or somebody might have missed, the more eyes, the better. I'm a true believer in that. Feedback is always great and important. Please make sure that you send that up, and we could take a look at that and make sure that if the changes are need to be put in there, we'll get them in there. So we want your comments as instructors just as well as our changes. Thanks, Brady.
And are these slides available to us right away? These updated slides?
The slides that are here are available to you. It's just like I said at the beginning, is that there's going to be some changes after next Thursday, Friday. The following week, it'll be put into the LMS. There'll be changes prior to it going into the LMS system. So you just need to be aware of that first.
Thank you.
Yep. And you can see the very front page, the first slide, I should say, of this training course will have, the most current date on it. Good. All right, so this is activity 5. This is just to get some basic facts, revisited here from the participants in the class. So I think we're doing this one in breakouts.
Yeah, you want to do the breakout? We've got it all set up.
Yeah, let's do it.
Okay. So the leaders of the group, you should know who you are. Just make sure you bring up the activity sheet for activity number 5.
Activity 5.
All right, here we go. We'll give you probably about 8 minutes or so, and then we'll close it.
All right. Let's see. So I guess I have to share my screen here.
You have to join your group.
Oh, join the group.
Yeah.
Where did that
Group
button?
1, breakout room 1, Bernie.
Where? Oh, okay.
Everybody.
Hey.
So I will share my screen. I have the activities. So this is a review, basic facts about COVID-19. Anybody want to lead this discussion? 8 questions.
Is it 2 to 14 days, number 1?
2 to 14 days is what I got for number 1.
Okay.
I think that question coming from Sean, he just volunteered himself, Alice.
Yeah, it did.
That's what you get.
Disinfectant. I don't know. Would it say on the disinfectant what you're using?
I think so. I think they're starting to put that on there.
I thought there was a list on the CDC website or something.
I know Lysol says COVID. It has for a long time. Most likely transmission mode. I would say.
It's was it droplets, right? Coughing.
Yeah.
Droplets, coughing, sneezing.
I guess with number 2, I would say manufacturer. Check with the manufacturer.
That's a good one.
Yeah.
I mean, you can't go wrong with that.
If it's
Germs.
approved,
Yeah.
FDA approved or whatever that is.
And there's an EPA website too that talks about cleaning.
Oh, gotcha. Probably all of them, WHO, CDC, and EPA.
Yeah. I don't know if we're going to share this or not, but I'll type it in there.
Okay.
So for number 4, you got what? Temperature, coughing, sneezing,
Coughing, sneezing, and
Shortness of breath,
shortness of breath.
and loss of taste and smell.
Would not having a symptom count as a symptom?
Yeah, just put a symptom.
It's not really the answer to the question, but it's a point, right?
Yeah.
Well, the next question is.
Oh,
Yeah.
okay, we'll get rid of that then. It won't be graded. True or false?
No, false.
False.
3 ways you can reduce your risk of COVID infection.
avoid large groups.
Coughing, sneezing into your elbow.
Yeah.
Wash your hands.
Washing hands.
Washing hands, yep.
I suppose wear a mask.
Mhm. Three ways that the employers can protect their workers on the job site.
Social distancing.
Hand washing stations.
Give them the proper masks.
Training.
All right, and the last one, true or false? COVID.
False. False.
All right. All right, there we go. Good job, guys.
I do want to mention the mask thing won't prevent you from getting it. It just stops you from breathing on other people.
Right.
I think there's a false sense of security with the masks and with the barriers and covers and all that stuff.
Absolutely. I think Harry earlier brought up an excellent point with, with us being essential and being out at work. Why is it getting downgraded to a cloth mask rather than being upgraded to a respirator?
Because we don't have them. We can't find them anywhere.
It's just not cost effective.
Right.
It's too expensive for the U.S. to make it.
Yeah.
We're not
A
important.
lot of the companies gave them away when this first started happening for first responders and stuff.
I also know that I'm sure the panic was just like fucking toilet paper and hand sanitizer and all that stuff too. People just ran and grabbed it because they kept hearing N95, N95, N95. So they're like, oh, that's the one we have to get.
Right.
But, I do know we're trying to order some KN95 stuff, the stuff from China that has the same particulate ratings, but I've also heard that they're falsely stamped, and some of them are good and other ones are just fake. They're not actually, they don't do anything. So who knows? We might run into some trouble.
Hey, Christian, if you're on Facebook, we have a health and safety page for DC 711.
Yeah.
And I actually put on pictures there about the actual stamping and what you need to have on the actual N95. So if you look it up, it's IUPAT, DC 711, FTI of New Jersey Health and Safety.
Gotcha. Our problem is in Washington, they won't even sell them to you.
Right.
They can have a whole pallet of them at Home Depot, but they pull them from the shelf and send them to the hospitals. So we have to get the KN95s. I don't even know if you've seen those. They're kind of weird cone looking ones.
Yeah.
But it's a challenge. I mean, luckily before it really got bad, we ordered a ton of HEPA filters before this thing hit for all our drywall finishers. And I mean, so far it's working pretty good because those last a lot longer than a regular mask too.
Guys, I need to break out of the breakout room, so I'm gonna close it. We can continue. That's a good conversation though. We can continue it.
Everybody's not made it back yet?
No, we're still waiting for Bernie's group.
That's a good, I like that activity, actually.
Yeah.
It's a good activity.
Hey,
Hey,
Ken,
Ken,
Yep.
have you heard anything about KN95s?
Yes, KN95s are tested different than N95s. And there's a lot of counterfeits that are coming in from the same area that say they're KN95s, but they're not. They're not as effective as N95, but they do filter out a lot more than a face covering would.
Gotcha.
But we have to be careful because there's a lot of counterfeits out there, and if you get onto the LMS system, We have a short video thing that Gavin put together from some information Bernie had that shows you how to tell the difference between a legit N95 or a counterfeit KN95 or a counterfeit N95. So there's some stuff underneath the LMS for that.
Oh, perfect. Yeah, because we ordered some and I haven't seen them yet. So I'm curious to see if we got real ones or not.
Yeah, if you get on the LMS, there's a short, I think it's like 2-minute thing Gavin put together. It shows you what to look for.
Okay.
Do you know the course code for that on the LMS?
If you go to the LMS and you look up top where the ticker is, where we're scrolling through, go to the COVID section, the COVID-19 section, and it should be underneath that.
195.
I got a question, Ken.
Beat me to it, Alice.
Omar.
So, viruses are normally broken down in 2 categories, DNA and RNA. COVID is an RNA because it keeps changing. The fact that it's all over the world at the same time, it can manifest itself in different atmosphere, different temperatures. So I'd like to know how or if vaccines are going to be able to help in with a virus that keeps mutating. Unlike a DNA virus that, measles, rubella, stuff like that, they don't change. It is what it is. You take the vaccine, it works. So
That's a great question, and you said one key word there, mutation. I'm gonna ask Bernie that question, as I think it relates more for an industrial hygienist to answer that. But just like isocyanates, when they start to dry, they morph into other isocyanates, which makes them more deadly. And so that's the same concept, and it's a great question. And there's still studies out on that. But I'll get Bernie to answer that a little bit more thorough.
So I just quickly looked that up because there's been some, so it's mutated, thus far a handful of times. Again, it's such a new thing. It's not well studied yet and understood. A vaccine, typically what they do, so let's take the seasonal flu vaccine. They do their best guess at what virus strains that recently occurred, they think it's going to come back again, and that's what they put into the vaccine. So it's not just one strain of flu vaccine. So when they're developing it, I don't know if they're looking at just developing the initial COVID-19 strain, or if they're looking at some of the offshots of what it has mutated into. But I just looked at some reputable sites. It's only apparently mutated into a handful of strains. And right now, that doesn't mean too much as far as concerning a vaccine and if the vaccine would be effective. It's a good question.
Thank you.
Thank you. I think we're.
Did you want to debrief the activity?
Yeah. Yeah, I think what I'm going to do so that we can move on, because I want to make sure we get through the ICRA part. Those are just some general, answering some facts about COVID-19. Does anybody have anything that they got hung up on or that they want to discuss, or did everybody, answer the questions okay? If I don't hear anything, let's just move on.
Bernie,
Yeah.
Bernie, our group had a question. So the global harmonization system, I probably butchered that all up.
No, you got it.
The new labeling of containers, do the companies that have the disinfectant have to follow that as everybody else?
Yeah.
Nice.
Yep.
Okay, that was it. That was the question.
We got through ours pretty well. We've got, everything was covered pretty good in the first section, so we were able to get through 1 through 8 with not too much problem.
Good. And the big takeaway is if your students can answer, it's airborne transmissible, I can be asymptomatic and still have it. And they can identify some controls, especially for the employer having a COVID-19 plan, they got it.
Very good.
All right, that was the end of that session. Ready to move on?
Let's go.
Are we having fun or what? All right, now we're going to get into ICRA. Let's see, next slide. So after completing this section, we'll be able to define ICRA and explain why it is used, describe how healthcare construction workers differ from regular construction workers, and explain the importance of following workplace rules using the designated areas for breaks as defined by the ICRA plan. So one of the things that I'll say though is not too much changed as far as the layout of this. Actually, I shouldn't say that. I changed some of the layouts of the slide, but I didn't add too much more content yet. But I think, you know, Ken and I are looking at doing that, including adding an example of a video of building a containment system.
Bernie, let me add this as we got instructors on the system here. I've talked to, I know DC16 is into it. That's, of course, my area. That's why I talk to them. But if any of you have videos of putting out a door, a zipper door, a T door, a Z door, any of that, or setting up a negative air system, setting up temporary walls, any of that type of stuff, sheetrock walls, or people tearing down sheetrock walls, we would rather have our members throughout this ICRA as pictured than the other trades, so that it just makes it our own.
Yep, and so I tried my best to find as many pertinent IUPAT member photos as I could, because again, I'm all about branding the stuff that you're showing to your members, make it applicable. Most of the stuff out there is from the carpenters. I did not include any of those photos. So hopefully in a month, most of the photos that I would find if I do an ICRA search for training will be IUPAT photos. That's my goal.
And just a plug for Gavin McDonald. I think everybody has his email address, not just ICRA photos, but he loves photos. So, you know, he might not use them or he might use them, but you know, if you got a photo you think could be used in something, please send it his way, because we're always looking for photos.
Right, and just if I can add real quick, we can use the instructor lounge to upload photos, articles, anything that you might be doing in your district council as a means for sharing that type of information. So you can upload photos, videos, articles, and things like that.
Thanks, Alice. That was a great catch.
Excuse me.
I have a lot of video of I have a lot of video of painters, and they're all in whites, and they're putting together a mobile containment unit. So we could get that on there.
Nice.
They're in the classroom.
Right.
Yeah.
All right, let's move on. These are just some more of our goals here. So basically what I did, I think I mentioned this the first day, I took out most of the infectious disease stuff that they had, which is very basic in the ICRA part. I moved it to the infectious disease module, and I only kept a few pertinent things in here. So it's more just specifically implementation of ICRA principles. Next slide. We can keep going here, more goals of the class. So what is ICRA? Infectious control risk assessment, developed in the 1990s to help hospital staff prevent infections from spreading within healthcare systems. You know, typically you're going to have an ICRA team within a healthcare setting or other settings, you know, develop the plan, and there should be some construction members as part of that development. Typically it'll be at, you know, like a GC type level, something like that, or superintendent.
I'm going to add there too, on the training department, or even on a district council's point of view, when you're getting members trained and you have all these members trained, what a great opportunity to go in and talk to these healthcare facilities and let them know that you got people that are trained within ICRA and that they know ICRA. So when they're building their plan, there's a possibility they might reach out to you to help develop that, especially today compared to yesterday.
Okay, next slide. So I'm only going to spend time on these that were significantly upgraded. Next slide, please. So springboarding, a very good segue, Ken. you know, Ken and I have talked about this a little bit, and we've talked about it with the IFTI staff. This isn't just something good for hospitals. I mean, this could be a leg of work for the IUPAT, which covers a lot of stuff, especially since, you know, projects often require hard walls, you know, permanent walls. You folks are the drywallers, the wall boarders. If you look at a lot of the surge hospitals that were put up, I mean, that to me looked like it was all potentially good IUPAT member work. But it's not just in the healthcare settings. We've got schools up here, daycares, anywhere where you want to prevent, you know, construction debris from basically contaminating something outside of your work area. It calls for ICRA. So there's a lot of good opportunity for implementing ICRA principles if you've got the population of construction workers trained to it. Ken, do you want to just add anything to that as well?
I'm good with that, but I want to answer this question. I think maybe everybody's seen it in the chat, but it says we need to remember all PPE required for the type of work, exposures worn in training photos. Absolutely essential. Please take a look at your photos to make sure that the proper PPE is being worn, because as you know, that just enhances what we're putting out there compared to some of the other photos out there that is incorrect. Sorry about that, Bernie.
Okay. Yeah, and if you see anything that I put in there for something like that, let me know. I try to never use negative photos unless I'm specifically bringing attention to doing something. Like for instance, there was an example of a congregation of workers for like a meeting, and it was like a big group. I left that one in there because that's something that we just don't want to happen. Another way to do it is show a small meeting with people dispersed. And I usually use the positive side of reinforcement more so than the negative. But if I find something that you don't like, you know, let me know why, and we'll look at taking care of it.
And the only thing on the ICRA used is, and I think we're going to talk about it, I think we're going to hit it, but surge hospitals, the ones that are being built up in parking lots and parks and all that stuff too, is they have to follow all these ICRA
Yep.
rules and regulations.
Yep. All right, next slide. Oh, back up one more.
Sorry.
That's okay. Rules regarding how construction workers behave. So I think we're just gonna, are we doing this one as a breakout room, or should we just maybe talk about this as a group? So we've got 40 minutes left.
Let's talk about it as a group, Bernie, and then that way it will give us maybe a little bit of time at the end to answer some questions and keep a little bit of QA from the folks, if you don't mind.
So how would you answer this question?
Well, if you're in a hospital, you don't want to be disrespectful to the other patients, pointing fingers at them or anything like that.
Yep.
Just making sure if you're in a hospital to stay out of the doctor's ways, because their job is obviously more important. And just wear all the proper PPE.
We'd have to
language, topic of conversations.
Yep.
And to piggyback on what we were talking about, just our not just our behavior, but our physical appearance in the facility. You know, that we maintain a professional appearance. That just because we're construction workers doesn't mean we have to come to work all dirty and sloppy. You know, put on a clean pair of work pants. Make sure you have a clean T-shirt that's not all worn out and dirty, and you know, maintain a professional appearance for our organization.
Good. Okay. Yeah. So
do as much as you can to minimize, you know, whatever hazard, dust, whatever it is we're doing. You know, using work practice controls.
Yep. Yeah. So the intent of that is just to basically get, you know, the participants to point out some things that, you know, might not work in a hospital setting like that, or not just hospitals, but, you know, somebody mentioned language. If you were doing ICRA practices or working at a school, right, or a daycare or something like that, you know, a lot of those same rules would also apply. All right, good. Moving on, next one. So here's going to just list some of these things that we already discussed. All right, move on. And again, that list is not all encompassing. You might have folks who bring up some things, some experience that they had that would fit on this list as well.
One thing that we forget sometimes is a lot of people have t-shirts in a drawer and they just throw on a t-shirt and don't pay attention to the graphics that are on the clothing. So we got to be careful of the graphics.
Yep. Okay, next. So here's some just, some rules. And again, this slide wasn't changed. So just things to consider if you're going to be working at a facility that's like this. Where do you park? How can you enter and exit the building? Can you go down to the cafeteria and eat, et cetera. You got to make sure that you're following the rules set up by the place of work. Okay, next. Confidentiality. So, you want to make sure that you're not looking at medical files, things like that. Don't repeat things that you might see, et cetera. Try to give, a modicum of decorum to the folks that are there. Next. Are there any alarms that you have to be aware of if you are working in a hospital? So what does code blue mean? Red and green.
Cardiac arrest, fire, and utility.
Okay. And next should bring us up our answers. All right, next slide, please. So these are just some issues to think about if you were to work in a setting like this. Immunizations, anything you do could affect the well-being of patients and care of that facility. So if you're sick, stay home. Notify the supervisor if you are sick. If you're immunocompromised, it might be a good idea to figure out if it was safe for you to go and do work at a place like that. For instance, I don't want to do any industrial hygiene work for Mount Sinai Medical Center in New York City right now. The amount of COVID-19 infection in there with my asthma would just not be a good mix. Next. Hospital hazards that are not on typical construction sites. What's MEP systems? What's an MEP system? Mechanical, environmental, plumbing, right? So these are things that you might have to deal with. I'm sorry, mechanical, electrical, plumbing. These are things that you might normally be able to lock out, right? Reroute, and you might not be able to do that in a hospital setting. Medical gas lines, gas pipes, helipads.
We have to remember what's inside the wall system. So if we're having to tear down a sheetrock wall and replace that and paint that, we really have to take in consideration what's behind that wall.
And with that said, do you think all hospitals are alike? Do you think there might be difference in working on doing some renovation or repair work maybe on a hospital that was just built 10 years ago to maybe a VA medical center in Jamaica Plain, Massachusetts?
Yeah, lead and asbestos.
Yeah, lead and asbestos. The age of some of those VA hospitals, I mean, the as-builts probably don't apply anymore. They might have stuff behind the walls that they forgot about, right? And you might get surprises. So you want to be cognizant of that. Other things they don't have on here, medical waste, right? Some hospitals have their own medical waste incinerators and laundry autoclave systems. Next slide. Hospitals are concerned about hospital-acquired infections. So hospital-acquired infection is something that happens when you pick up a bug, a pathogen, from a hospital, and they're pretty prevalent. And could I share my screen for a minute, Alice? Because I brought this up, and I wanted to show folks this example. And I'm going to end up putting it into the system, into this presentation here. All right, so share screen. What do I want to do here? Can folks see this okay?
Yeah.
All right, so I don't know if I don't want to go through the whole thing, but back in 2011, there was a superbug that escaped basically from a woman who was transported from a hospital in New York to Bethesda, an NIH hospital in Bethesda. And it was immune to antibiotics and control. And so I bring this case up, and I talked about this during the Ebola outbreak when I was giving train the trainers on this. The NIH Bethesda Medical Center is like the cream of the crop. This is one of the places you think that they would have everything tight, right? And yet this infection got out into the hospital. It ended up infecting, I think, I had the paragraph up, darn it. Let's see, 17 people became infected besides the one patient who brought it there from New York, and 6 people died. So this is an example of a hospital-acquired infection that got out of control, and it was something that was resistant to treatment. So hospital-acquired infections can be significant, and it's something that we have to be cognizant of. And I'm going to add this example to the slides for our next go-around. Okay, I'm all set.
That was good bringing an example in of that too, because I think that hits home with people when they could read something.
All right, next slide, please. So here we're bringing back the chain of infection. Folks should, have a really good handhold on this already. They, did an activity where they answered some questions about it, but we're going to use the understanding of this to prevent transmission of not just pathogens in the hospital setting or a school setting or whatever, but also, transmission of other things like dusts as well. Next slide. So the most common ones associated are bacteria, fungi, and viruses. Next slide. Oh, I thought I had slides of those in. Must be I ended up putting some photos of some common ones in there. So serious infections or death can occur when mold is inhaled and enters the bloodstream. So here's an example of some mold in a hospital setting. And again, mold is going to be something that could be fairly common, with doing renovation and repair, water leaks. And, how many sources of water infiltration into a hospital do you think there could be? Is it just from a bad rainstorm? How else could water infiltrate a hospital setting?
There's a number of ways. Leaking pipe, it could come from the HVAC.
Yep, HVAC, condensing units, drip pans. Good.
Mopping?
Mopping, yep, good. Okay, next slide, please. So here we got Aspergillus and Legionella, some common construction-related HAI pathogens. On the left there, we see a nice interior of an HVAC system, which is typical of what I see when I do indoor air quality investigations. And then on the right is an example of, if you click one more, I want to see if I got a text box in here for these. Oh, I don't. It was an actual investigation, I think, of the New York Department of Health at one of the New York City hospitals where there was a Legionella outbreak. Next slide, please. Here's some hospital areas that should be considered reservoirs. So remember, we talked about the reservoir was what? What's a reservoir for the chain of transmission?
A human.
Could be a human. What's the definition of the reservoir, though?
Something that's got the infection.
Exactly. Yep. Something that's got the infection. So it's a natural habitat. It's the home for the pathogen.
Okay.
Right. So there's a few examples here behind drywall, ceilings and plenum spaces, ductwork, plumbing, cooling towers. Anything else you can think of?
Bertie, I would like to add something to that though, because as ICRA was designed for protecting patients, that's what ICRA was designed for. We also have to protect the worker that is sometimes overlooked. When you're tearing down stuff like this, there's hazards that you can't see that are behind these walls. So you have to take that in account of what kind of protection or engineering or administrative controls you're going to use when you're doing that type of work.
Yep. Absolutely right, Ken. Okay, next slide. So here are just some examples of pathogen portals of walls, doors, ductwork, ceilings, plumbing. Next slide. So the ICRA planning considers different transmission modes: airborne, waterborne, surface or contact transfer. Next slide. So the portal of entry, remember, is the opening that allows the pathogen to enter the host. So, you might not be in direct contact with any of the patients there that might be immunocompromised, but the work that you're doing, or even you being in the area, might be, a portal of entry. From you breathing, coughing, alleviating dust, opening up a wall, where now you've got, a pressure differential and you're releasing whatever's in that wall cavity. So you, as the work that you're doing, could actually create some portals of entry.
I kind of go back to what I said in the group about face coverings, and you see people just covering their mouth and their nose is exposed. And I go, like, they're not breathing through their nose?
Yep. Training, right, Ken? We got to train them.
Training is the key.
Yeah. All right, next slide. Again, immunocompromised folks are the ones that we're really looking at to protect with, these risk reduction precautions for infection. Next slide. This is some example of some folks who might be immunocompromised. This is a huge list, but just, it's a short list. And again, you might be somebody that's going into the work environment to perform the work that's immunocompromised. Next slide, please. So this is a planning tool that's going to, minimize or reduce the risk of hospital-acquired infections and protect those patients that might be at risk. Next slide. We can keep going. These here are ones that they've already seen. I didn't mention these here. All right, so I should say I didn't rearrange them. So this is the general layout of how ICRA planning is going to go. CDC has some good resources for ICRA, promotion. So you're going to identify the kind of construction activity that you're going to be doing, identify the patient risk groups that might be affected. Because again, you're not going to be, working on the whole hospital or the whole daycare center or something. You're going to be probably confined to a certain area. And then match the type of construction project activity with the patient risk group in a matrix. And then you're going to look at the level of precautions, and that's going to assign it a class level from 1 to 4. Next slide, please. So this is our step 1, is going to be looking at the types of construction work you're doing, from small non-invasive activities all the way up to major demolition and construction projects. And type D is going to be your most intrusive form of construction. Next slide, please. We've got our patient risk groups: medium, high, and the highest risk. And next slide. And from there, we're just going to basically put those things in a matrix. So you're going to look at your patient risk group across the top, with the type of, I should say, the construction project type there across the top, A through D, with your patient risk group, and that's going to give you your level 1 through 4 of ICRA, or I should say class ICRA work that you're going to be doing. And
that's for every activity that you're doing on a job site. So your crew might be split up in different categories here, depending on what tasks they're performing.
Yeah. Next slide. And these are our ICRA precautions. So we can see, like, we'll take class 3 for an example. Remove or isolate HVAC system in areas where work is being done to prevent contamination of the duct system. Use critical barriers to seal areas from non-work areas. Maintain negative pressure with HEPA units. Contain construction waste before transport in tightly covered containers, and cover transport receptacles or carts if cover is not solid, and cover must be taped closed. All right, next slide, please. And this is what you would do upon completion of the construction. So You know, you're going to have to almost go in reverse order and make sure that anything that you're doing to break the job down and to terminate the project is not going to create a risk to hospital occupants.
And it's important to know that, say, we're looking at class 3 precautions. So in other words, class 1 and 2 are also in play.
Yep.
Yeah. In addition to.
Yeah, I mean, a good way to look at that, a good point, you know, the higher classes cover everything underneath it.
There you go.
Yep. Yep. Good add. Okay, next slide. So we're just going to go through these quick so I can get to the final activity. So, you know, you've seen these. I did update some photos and such and do some rearranging, but you can scroll through again, Alice. Preventing dust with the different methods that we know how to employ. Keep going, Alice. You know, these are different, some dust control methods. Next slide. And again, these are things, I rearranged the slides a little bit, but try to put in some IUPAT photos. There's an example of, I think these are stills that Ken and Gavin grabbed from a video that you guys have.
I think that's called a Z wall,
Yep.
if I remember the name correct.
Yep. Next slide. Here's an example of a temporary portable enclosure. Next slide. And you're going to match the size enclosure and barrier that you're going to have with the kind of work that you're doing, the level of construction work with your patient susceptibility. And you know, you're going to have to size the amount of negative air units that you've got to get the, you know, the required air exchanges and create a certain level of negative pressure. 2 inches of water is not a bad way to go, since that's what we use, you know, in asbestos abatement, and it's also recommended to, you know, go to the same level for if you're doing mold abatements and things like that. Next slide, please. So you got to make sure that your entry doesn't create, you know, an area or an opportunity for dust to escape. Next Next slide, please. Here's an example of a long-term barrier. And make sure that everything's sealed up nice and tight. Next slide. Look at that, Alice, you were looking at my mind. You transitioned the slide even before I could say go. That was perfect. Anteroom, so this is a separate work area. You know, again, it's an area where you can make sure that you're changing your PPE, donning and doffing it, and it's another level of protection to make sure stuff does not escape. Next slide. So this is patient protective apparel. So what's the difference between PPA and PPE?
PPE is to protect you.
Yep.
And obviously you are trying to contain any contaminants that you may have against the patient.
Exactly. So if, you know, by vacuuming yourself off, you didn't catch everything, or your sticky mat or whatever, you're putting something else over you, a gown, you know, booties, etc., to contain anything that you might have on your body. Good. All right, next slide. You know, there's a different types of material. And again, the type of apparel is going to be listed in the ICRA plan. Next slide. There's a certain way that you want to remove it to make sure that dust is not spread. Next slide. So here's our activity that we can do in the breakout room. I want to just go through this together since we've got 18 minutes left.
Let's do that. Let's do that, Bernie.
Yeah, this is the one that you've done before on the class, and we just kept it in here, so it's good. So the scenario is you're going back to your work area after lunch. You're wearing foot covers once inside your work area. You realize that you left your reading glasses in the lunch area, and you need to go back to get them. And on the activity sheet that you've got, under activity 8, I listed out 1 through 9 steps there, and they're not in the right order. So you'd have to go through and order them in the correct order. So I don't know if that's listed on the next slide or not, Alice, I can't remember. So here's the answer to the question anyway. So again, you know, if you're doing this virtually, you can enter some breakout rooms and you refer the students to their activity packet. Number 1 through 9 up here are going to be in a different order. And note to self, Alice, I'm going to make sure I put 1 through 9 on those bullets instead of bullets to match the activity packet. So this is, or if you're doing it, you know, in a classroom, you can There's a bunch of different ways you can do it. I've done ordering activities like this before and face-to-face training where I've actually cut them out and laminated different steps. And that way there, I would just give them in like an envelope to the class groups, and they'd shake them out on the table and they try to reorder them in a certain way and then maybe paste them, tape them on flip chart paper or something like that, easel paper to hang up. There's a bunch of different ways you can do it.
Hey, Bernie, I'd like to add to that because
Yeah.
a scenario like this is bound to happen. And we know that, that somebody's going to forget something or we're going to have to grab something. And we can have the best plan, we can have the best procedures in place, all that. And one issue that we forgot something and we didn't follow the procedures could be hugely costly to a life, to the worker and the patient. So it's really something you need to explain to the workers, that they have to follow everything no matter what the circumstances are.
Yeah. And this is ICRA. I mean, this is a policy. So as far as our hierarchy of controls goes, this sort of falls under an administrative control, yet it's got a lot of aspects of the different types of hierarchy of controls in there. Everything from engineering controls, like with our HEPA units, to our barriers, to PPE, and then some of it's behavior. And I hate using behavior as a way to control a hazard because we're terrible at it. The number of times I've tried to either eat a certain food or cut a certain food out, or make sure I do this or that as a behavior, I fail so many times, even on stuff I love to do. So when we're looking at worker behaviors, it's tough to do. So anything that you can do to transfer to your students on methods that they can try to make sure they're following the right procedure or behavior is really important. And there should be checklists posted around the site, things like that, reminders for workers to be able to do the right order of operation, the right standard operating procedures, etc. Because they're tough to remember. And with strict stuff like this, I don't, discipline procedures are usually a little more strict as well. All right, next slide. So this is just going to get into controlling, the air. Next slide. Here's a great example of, negative air pressure being maintained. You can see how that poly barrier is getting bent in, getting sucked in. That's because that unit is drawing the air. All right, next slide. Just some, different systems we've got there, and of course the definition of high efficiency particulate air. Next slide. We got a magnehelic gauge there. So again, you want to make sure that negative air is always maintained throughout the project. Just because you go home at night, if you shut down the job because it's only, one shift or maybe two shifts, you still got to maintain negative air to make sure nothing is released into the hospital environment. Next slide.
Can I add something to that,
Yep.
Bernie, if you don't mind? And you also have to keep in mind that you probably need to have in your plan that that you're communicating with the building engineers or their HVAC person, because if they change the air system within the building without knowing what you're doing or trying to do, they can create a over negative pressure, which tears down the containment completely because it sucked it all in, or they can create a very positive situation, which could be, blowing stuff out the other way.
Yep, good point, Ken. All right, Alice, I think what we'll do, maybe just skip through slides somewhat slowly to get us towards the activity. I think we got like 15 left or something. So these are all things I've just added new photos. I'll talk as you go. Gotta make sure all your waste is covered. The one at the bottom, I think if you click, there's gonna be an X on that photo. Yeah, that's a no-no. These here are some examples of covering the materials that you're bringing into and out of work environment, cleaning down your stuff. I added some photos there. It would be good if we can get some IUPAT ones there, because those are just general ones that I grabbed. Hospitals can affect workers as well, the hazards that they might have. You've already mentioned asbestos and leads of older buildings. biohazards, bloodborne pathogens, mold might be there, ionizing radiation, all kinds of good stuff. All right, you can keep going, Alice. These are just slides that cover all those hazards. Just a quick thing on the, the ionizing radiation stuff. All those sources are sealed. However, as part of the radiological material license that any medical facility has to have with the state, or in some case, if it's a partnered state, then they would actually fall under the NRC, the National Radiological Commission. They have to make sure that those sources are inspected annually. I have actually evaluated a source that was leaking in a medical facility. So it does happen. It's not often that it happens, but it can happen. Pay attention to your surroundings. This wasn't changed. The medical folks always have the right of way. All right, Alice, let her go. All those common construction hazards are still there that you're dealing with, right? All this stuff is the same as it was with the original program that you went through. Signs, got to make sure these are posted. All right, so here's our final slide before we get to just a bunch of slides that are review. And I didn't update those yet or change them. They will have to be, though, to match the new COVID updates and the infectious disease stuff. Or we could just take them out altogether if we want to do a different type of review activity, but we'll talk amongst ourselves and figure that out. But this is an activity to actually go through ICRA. So this is one that we would do in our breakout groups. So how do you want to do this, folks? Ken, I'll defer to you here. So we've only got 10 minutes. I'd like to at least do a 5-minute.
It's I think let's just have a discussion here, Bernie.
Okay.
And then I think it's important for the participants, members here, to have some questions at the end if they have them. So.
Okay, so maybe if you just want to flash up the screen, Alice, of activity 9. So what we did is I just came up with a little activity here, review the following renovation scenario to be conducted in a post-operation recovery wing of a hospital, and answer the following 4 questions regarding ICRA work. So basically there was a storm, 2 windows leaked in 2 different rooms that were adjacent to each other, so they were separated by 1 wall. Actually, I should put in here too, this happened 2 weeks before you're about to do the work. And basically what happened was the drywall, the tape, joint compound, paint, all that stuff bubbled up. It was effective. It's soft to the touch around the windows. So your job is to demo all that stuff and put it back as normal. With that said, we've got some descriptors of the hospital here. It's a post-operation wing. The rooms, obviously, that you're going to be working in are not occupied, but there are folks that are in that wing recovering from operations. You have to go down a 50-foot hall from an elevator to access the rooms. And that's the scenario. And then you've got a little job scope here, about 160 square feet of wallboard total. Drop ceiling, linoleum, tiles, windows, and blinds are in good condition. And then we've got our 4 questions. So we'll just scroll down and look at what these are. So what construction activity is this under ICRA, A, B, C, or D? If patients in surrounding rooms are recovering from surgeries, what do you think the risk group is, or risk category? What class of ICRA work construction would you assign the project, 1, 2, 3, or 4? And list 3 to 5 ICRA controls that you would want to ensure are implemented and followed. I think that at the awareness level that this class is taught to, if you have workers go through this scenario and they can answer the questions well and have a decent discussion around it, I would feel confident that they picked up the idea of ICRA at an awareness level. And you don't have to be married to that kind of description, but it's one that I've seen happen many times in healthcare and assisted living facilities where I've been called in to respond to a rainstorm or a water leak where there was wall damage, wallboard damage, paint, wallpaper, etc. and the stuff had to be repaired. And the reason why I'm going to put in the description, this happened 2 weeks ago, is because mold only takes 24 to 36 hours if the place is not dried out well for it to start to propagate. So if it happened after a few days or a week or something like that, there might be the issue of mold, and maybe one of your students would bring that up as well. And I can highlight that in like an instructor guide for this activity sheet. With that, I guess I can conclude the delivery of this. Like I said, the next few following slides are just what the CPWR had in there to review the COVID and ICRA stuff. I should put some stuff in there for infectious disease and update the ICRA module, or we could just cut that all together and suffice with a general review activity for the whole class. With that said, Ken, I'll leave it up to you to carry us home.
Before we go into questions, Alice, I want to ask, or I see Tom too, but I just want to ask the question to the curriculum department. So the instructors that are on this class, is there any evaluations or anything like that they need to go back to the course code and do? Alice? You there?
You know what? I need to check and make sure there's a survey up there. So I'll put one up there if there isn't.
Okay, I just want to make sure that we got everything.
So I guess, folks, it looks like I already thought ahead of myself, and I guess I did put review questions in for the infectious disease. One less thing I have to do.
So let's open it up with questions. Let's respect each other. We got 21 people on the line here. So let's take a few, and if you got questions for Bernie, let's ask some questions, or actually for anybody that's on the call here.
Hey, Ken and Bernie, I wanted to ask real quick on final activity, activity 9. So those 4 questions, the participants will have to have material to kind of go back to look at that matrix. So my question is, how do we work that? Do we kind of put slides up somehow, a slide that would show the matrix so they could all see that while they're in the breakouts? Because without that material, they're going to be kind of stumped at that point.
So good question. I guess that would be something for the IFTI to consider. If you want to give like a printout of the notes in a PDF form or something, it's up to you guys. If not, then yeah, we can put it in that activity pack.
I think in that activity pack would be a good idea.
Okay, consider it done.
Next.
Not to be a dead horse here, but the UV light thing, Bernie.
Yep.
When you're outside, is that I don't want to say safer, but is it less of like a bright sunny day? Is there less chance for COVID to be spread being outside?
Yes. So UVC A and B light does destroy the virus so that it's not infectious anymore. I haven't seen a lot of studies, though, contrasting outside UVC yet compared to indoors with no UV light at all exposure. But yes, your risk would be less, not just because of the UVC light bombardment, but also because of the great general ventilation that you would have.
Thank you.
Yep, you're welcome. Good question. That doesn't mean that I would want to go outside, though, in a pool party.
Any other questions? Comments on the class, even?
I'd like to comment. I found this class to be exceptionally informative, and look forward to sharing that.
I second that.
Now, I have a question. You guys, I kept hearing you guys say about next Thursday and Friday. Is this something that we're gonna do again next week, Ken?
We're actually doing another group next week. So because if we get too many in a class, a Zoom classroom with the questions and all that stuff, it just becomes too much to manage, right? The same thing as you doing a class at your facility, is you're not going to want 40 people on a Zoom meeting as you're trying to do it. You're going to break that up, and that's what we're doing.
I just want to say thanks, Bernie, and Ken. Bernie, you're a wealth of knowledge. It's impressive.
No.
I always tell Bertie when I'm talking to him, because I sit around a bunch of IHs, a bunch of them, and Bernie comes from a different world than the other IHs. I'll just say keep it polite.
They get real nerdy, huh?
Hey,
Bernie, Bernie, with all your knowledge, do you ever leave your house knowing all these things are out there?
Oh yeah. Oh yeah. Because I reduce my risk to them. I know how to reduce my risk. I'm empowered through education, which is what we do as trainers, right?
Yeah.
Hey Bernie.
Yeah.
Could you just tone down the New York bashing a bit, you know, Mount Sinai, you know, and all this other stuff? Please.
Hey,
good people, man. A good friend of mine works as an ICU nurse in Mount Sinai.
Good job.
You can handle it all, man.
If it wasn't for New York, we'd be in big trouble.
So I would like to add, so everybody's knows this. If you haven't done Zoom classes, you want to do ICRA and COVID-19 training. You're still a little bit unsure about what to do. I just want to make sure that we have an opportunity to break down those region walls. Alex, which is the director of training at DC 16, has offered any of his instructors to help hold a class, a Zoom class. They've been actually practicing with their other instructors holding classes. So he's willing to do that. It's, I think the instructor lounge that we got that you can find on the LMS is a way to communicate that we're holding classes, but I think that we just have a prime opportunity here. We can have up to 4 instructors, teaching the ICRA COVID-19 class that would be covered. So, let's reach out to each other and share this resource, and instead of just trying to be that one person trying to do it all. We have that opportunity. But I just wanted to extend that handout of DC 16's instructors, which we have some of them on the call today that are willing to teach with anybody to get this through.
Yeah, I just want to say, folks, thanks for participating in this and for asking such good questions. And I've worked with a lot of unions, and I've trained a lot of master trainers, and I've been doing this for 25 years. I am very confident in the IUPAT's ability, to promote good health and safety through education. And I'm telling you, all of you can do a lot of good for your members' families, and the general public, because good news spreads. By teaching this course, and it's going to be a good thing. It's one good point in my week was doing this Train the Trainer for you guys. All the other news was bad, except my birthday. My birthday was fun.
So on the chat box, it says, please visit CORE, COR 1147 and take the end of the course survey for the live presentation. So it's make sure that we take that survey.
Will do. Bernie, I had one
correction. I have a correction. It's FTI 1147, not CORE. FTI 1147. Thanks. Sorry about that.
Bernie, just one more thing. I hope you don't take this as an insult. What are your credentials? Just so I can, when I tell people this information, I don't want to just say that I heard it from some guy. You know what I mean? So you're obviously an expert in this stuff. But when I related this information, I want to be able to tell somebody why you know as much as you do.
It's going to take about 3 sheets.
That's great. That's awesome. That's great.
So you can say you heard it from this Polish guy in New Hampshire, or you can say that you heard it from an industrial hygienist who happens to be Polish and lives in New Hampshire, who has a master's degree in industrial hygiene from an accredited engineering and science approved university. I have 25 years of experience. I'm a certified industrial hygienist. I'm a certified environmental trainer. I am certified in Homeland Security at the highest level 5 for health and safety response. And I'm a registered professional industrial hygienist.
Now I'm getting writer's cramp. You're killing me.
Awesome.
I can't even keep up.
Thank you, sir.
You're welcome. And I don't take offense to much, so.
What's your card look like?
I haven't used a card in a while.
Two-sided.
I usually don't say that.
I think he'd
too
have a
much unless
Rolodex.
I'm trying- Yeah.
Might
I
be
usually don't. I usually don't tell people what I got in my back pocket unless I have to beat somebody over the head with it because they're another expert and they're trying to be a jerk.
Mm-hmm.
Probably look like the Nash pocket guide, huh?
Hey, on another note, I'm on the LMS right now and I'm looking for 1147 FTI. I do not see that for what it's worth.
And this is a question just as a reminder for Ken and Alice. And what do they have to do to record the class for making sure that the CPWR can count attendees for the grant? Is that an issue?
So Nicole is actually, Nicole, if you want to speak on this, you can. That would be great. I know that she's on the call here, but Nicole is finalizing some things to actually do that because you're, as instructors, are a point person within your district council, will be working with CPWR directly for billing. The thing that we are requesting from all you is we would like a roster sent to the IFTI of participants that you are training. And let me tell you the reason for that is because I'm a firm believer that there's going to be another pandemic. If we get the phone call at the IUPAT, how many members do you have ready to help us? We want to give them a pretty close to accurate number. And so without some type of tracing for that of the members taking it, then we won't have that number. And we'll just, I'm going to say that we're not going to look prepared. So one thing is we're going to need a roster sent to the IFTI International, just like we would if we were holding a regular class. And that would go through your ATR. So the director of training would go through his ATR, which would make sure that gets up to the proper folks. Then that would be sent to CPWR, and then CPWR will work with you as a district council on the billing to get you reimbursed for your grant money. But to get that grant money, your participants or your members will have to do a registration paperwork, just like any other CPWR grant class, and then they have to do an in-a-class survey, just like any other grant class, and those two the registration and survey is all done online. Did I hit that, Nicole?
Yep, you did a great job, Ken. We've tried to simplify the process a bit so it'll be a little bit easier for you guys to work with your DOT, and we've tried to cut out a little bit of the red tape, but most importantly to get to us is those rosters. We have a template for you to request the wages and hours for your trainers who conduct this from a distance. And I have all of that pretty much ready to go for everybody. So when you start training, we should get this out here pretty soon, but when you start training, we'll be ready to go, and you guys will work directly with CPWR for your reimbursements for those.
Any other questions? We're about 12:08. So in respect of everybody's time, I'm going to say thank you. You were a great class. Great questions. And now it's time to share this with our members and get our members up to speed so we're keeping them and everybody else around them safe. So thanks, everyone. And we got a closing music.
Thank you, Ken.
Thanks,
Thank you,
everybody.
Bernie.
Have a good weekend.
Thanks, everybody. Have a great weekend.
Have a good weekend, everyone.
Yep.
All right.
Have a good weekend. Have a good one, Ken.
Yeah, you too.
Thanks, guys.
Behave yourself.
Never. I'm at your cabin right now. See the Northern Lights.
Nice.
Got some bookie on the side, my mom was trying to hide.